All right, and back over to
Great.
Nour and Gord.
Yeah, thanks, Melissa. So, just to review sort of our objectives for the evening, first off is to really understand what a nurse practitioner does, what a nurse practitioner role would be in Ontario, and the requirements to gain and maintain that designation. To understand the business model for hiring a nurse practitioner in the family health organization, or the FIN is the other one, patient enrollment model. I could specifically refer to the FO model here. There's very few physicians that are working in the family health network model anymore. And it's important for us to note that the model for bringing on nurse practitioner only really works in a capitation business model. And so we will discuss that a little bit further. And lastly, just to create some connections between nurse practitioners and family physicians in the Middlesex, London area. Next slide. So just giving you some background to why we got this presentation today. And so when we look at sort of our Middlesex, London, Ontario health team, we know that we feel that primary care is really the foundation of the strong healthcare system. And one of our key performance indicators to the ministry about 2 years ago, when we initially got our transfer payment agreement, was access to primary care. From the Inspire PHC data, we know that there's at least 65,000 individuals in the Middlesex, London area who are unattached to primary care provider. It's probably growing every day as we speak. And we know that based on the Inspire data, that only half of those are actively seeking primary care. So that's always an interesting thing to know, that some individuals who don't have a provider actually aren't really looking for one. Nonetheless, we have had discussion with our sisters and partners here, and we know that there are multiple reasons for the unattachment in our area. We could go to have a long conversation regarding that, but that would be out of scope today. And really, we want to look at what are the challenges for us in primary care and how we can align at the OHT our principles of equity-driven quadruple aim. So our next slide. So over the course of about a year and a half ago, the Middlesex, London, Ontario health team, we developed a working group with a number of family physicians and nurse practitioners to talk about access to primary care. And as a result of those co-designed sessions with those individuals, we developed 4 key work priorities. One was develop a coordinated recruitment transition into practice program, which has led to the hiring of Andrea, which we'll talk about shortly. The second one is how to empower and enable healthcare workers to work their full scope, whether that be NP, RN, RPN, or medical office assistants. How to decrease administrative burden through increasing awareness of digital tools and helping improve your capacity or reduce your administrative burden. And lastly, how we can advocate for increased funding and size of primary care teams and resources within team-based care. So what we're specifically focusing on is item number 2, and then sub-focusing on is the NPs today. So we'll just go to our next slide. So again, we'll move on full scope here. So again, as I said, we're going to be focusing on the nurse practitioners today as one of our change initiatives. We'll move on to our next slide, Melissa, thanks. So we want to ensure that we allow healthcare workers to be able to work at their full scope of practice. This allows improvement in the satisfaction of just doing your job and improving the practice effectiveness, but also can decrease the risk of burnout. So in turn, as family physicians working in sort of independent in businesses, is how we can ensure that our staff who work around us and our team members are working to their fullest scope to maximize their capacity and their skills. And then in turn, we need to look how we can match that skills with their expertise so that they are working efficiently. So that's kind of one of the things we want to look at today. Yeah, next slide. So let's talk about nurse practitioners in Ontario. I'm going to hand over to Nour.
Thanks, Gord. So just before I start, I'm just going to reiterate that I'm an NP that works in a FIT model. So I don't think it's a conflict of interest, but I'm certainly not the expert when it comes to this. So in our second half of our presentation, we're going to have wonderful panel members who will speak to their experiences within the model that we're discussing. And certainly the topic of compensation is going to come up. And I just want to be clear that this town hall is to discuss potential solutions in a healthcare system that's not perfect. And numbers represented may not accurately reflect the current market, but we do our best just to kind of give everybody an idea. So these next few slides may be a review for some. It's just important to understand how one becomes a nurse practitioner and what an NP does in order to facilitate that MD-NP relationship. So nurse practitioner or RN in the extended class are protected titles. So all NPs at some point were RNs. In my program, when I look back, I think kind of the average amount of years of experience an RN would have when they were in the program was about 7 years. This can vary though, and the minimum requirement, from what I remember, is 2 full-time years. So the CNO is the regulatory body, the College of Nurses of Ontario, and it governs the RPNs, RNs, and and NPs. The requirements for NPs is there's that formal education piece, the evidence of practice, the board exam, if you will, the jurisprudence exam, language proficiency in English and/or French, and the authorization to work safely and ethically. NPs have an expanded scope of practice that gives them the authority to diagnose, prescribe medication, perform procedures, and order and interpret diagnostic tests. Can we go to the next slide, please? So in terms of membership obligations, so in order to maintain good standing, nurse practitioners are part of the CNO Quality Assurance Program, which includes quality assurance assessments such as patient case reviews and other types of assessments, and this is done in random selection. There is compliance with NP standards. So these standards are designed to protect the public, and these cover things like therapeutic management, guidance for the use of controlled substances, conflicts of interest, legal requirements, and restrictions. Anything in blue you see here on the slide, and we hope to share these slides if we haven't already, they are all hyperlinked to the appropriate document for your review. Just too much to really go over now and quite boring. So we'll just leave it at the hyperlinks. When I completed the program, and I think it was around 2015 or 16, NPs couldn't prescribe controlled substances at that time. So I had to go back and do a course. I did it through the University of Ottawa. Now, to my knowledge, from 2017 on, this controlled substances requirement is actually embedded into the program itself, which is good. And NPs are required to have professional liability protection. So most seek this out from the Canadian Nurses Protective Society, so the CNPS, the NPAO, the Nurse Practitioner Association of Ontario, or the RNAO, the Registered Nurses Association of Ontario. Next slide, please. So this slide quickly just highlights that NP is a protected title, and there may be many ways you'll see it written. So most commonly you'll see MNNP or RNEC. EC just stands for the extended class. There are other NP titles based on different types of specialties, as you see on the slide there. But most commonly, you'll be working with nurse practitioners who work within primary care. They also use, we also use NP-PHC, or as you saw, I had MNNP-PHC. I guess I just feel like it makes me sound smarter. I don't know. As long as it says NP or RNEC, you know you're working with an NP. We'll just go to the next slide, please. So if you remember anything I said so far today, it should just be this slide. It's just basically through all the explanation of what an NP is and how one becomes an NP and maintains their designation. It's just important to note that NPs are regulated. They are autonomous and they're accountable to their own practice, which means we have our own billing number, a registration number for prescriptions or ordering tests, which is like the MD CPSO number. NPs are funded, government funded in certain types of models, which we know are the FITs, the CHCs, the NPLCs, AHACs. You'll also see NPs in tertiary care doing things like stroke care, cardio, hematology, everywhere. What we're discussing today is what's in red, is creative models in an imperfect healthcare system. So it's not to say that what we're proposing is by any means perfect. It's just a creative way to work within the constraints that we have to improve accessibility, decrease your burden, your stress, and your burnout. And we have people here who actually have been doing this for a while with success. So that's why we're excited to share it. And finally, there is no I in NP. So this point is just to highlight the importance of mutual respect for both professions, and that collaboration is key. There are NPs and MDs share a lot of the same battles as do our patients. There are NPs in primary care and MDs in primary care. And my hope is that when we finally get our perfect healthcare system, that's a lot of hoping, but I hope it includes both professions working together to their optimal scope and in optimal conditions. But this for now is kind of what we got. So we'll just go to the next slide there. basically what this slide is trying to say is that as NPs, we have a very wide scope of practice. And of course, experience and comfort level do come into play. So where I was 7 years ago to where I am now is night and day. And I'm sure no matter what profession you are, you probably feel the same way. So basically, you know, if an NP and MD work together, they want to look at the unique needs of the clinic, they can basically talk together about what works best, but that scope of practice is very wide. So what I'll do now is I'll just pass it on to Gord to proceed with the finer details.
Thanks, Nour. So I'm just going to go through sort of the concept of how to bring on a nurse practitioner in your practice and things to consider. So we do know that nurse practitioners can work within their own scope of practice, and family physicians cannot bill OHIP for nurse practitioner services for what are called assessments, consultations, psychotherapy, or counseling. So when we talk about assessments, we're talking about your A001, your A007, your A003s, your K005s, you know, those type of billing codes that are typically assessments. You are not allowed to bill those for a nurse practitioner service. You're only allowed to bill OHIP under the physician's number for delegated procedures. And I have that in quotes because these are ones that have been defined by the OHIP schedule of benefits, which I'll go into in my slides shortly. Simple office procedures can be provided and billed for without a physician's supervision, and these are under the delegated procedures. And for our other delegated procedures, a physician needs to be physically present in the clinic for the service to be payable by OHIP, but there are some exceptions, which I'll go through. So next slide. So the term procedure, according to the schedule benefit as it's used, does not include services such as an assessment, consultation, psychotherapy, or counseling, as I mentioned before. The rules, though, for a procedure is that when it's performed by a physician's employee in the physician's office, the service remains insured if the following requirements are met. One, the procedure is one which is generally and historically accepted as a procedure which may be carried out by the nurse or other medical assistant in the employ of the physician. So I'm going to point out here that the schedule of benefits has not been updated in probably 25, 30 years. It has not mentioned anything about nurse practitioners in it at all. It only talks about nurses and other employees of the physician. So that's unfortunately a potential barrier in our ability to extend the billing concept within nurse practitioner practice. But that is what exists, and that's the current state of the way OHIP is. But there are exceptions, which I'll go through shortly. And so at all times during the procedure, the physician, unless they're otherwise occupied, must be physically present in the office and when the service is rendered in order for the insured service to be covered, and must be available immediately if they need to modify or otherwise intervene. The exceptions is really, really important, which we're going to go to the next slide, because this is where the nurse practitioner element really fits in. So I'm going to go to the next slide here. The exceptions for the requirement of physician presence during the delegated procedure are, so when all of the following conditions are met, a simple office procedure listed in the table below remains insured. If the non-physician performing the procedure is properly trained to perform the procedure, he or she reports to the physician, and the procedure is rendered in accordance and accepted with professional standards and practice. So for example, this could be even to the extent of doing procedures like biopsies. If you feel that your employee is properly trained and has had a proof of that so-called training, then they are adequately able to do this without your presence being there. The procedure is performed only on the physician's own patient, as evidenced by either an ongoing physician-patient relationship or a consultation assessment rendered by the physician to the patient on the same day as the procedure is performed. And the same medical record requirements must be met if the physician personally has rendered the services. So the records must be dated, identify the non-physician performing the services, contains a note about the procedure, and the person who's done the procedure should actually be signing the note. So a proper clinical note in this case. So next slide. Most services listed in the schedule of benefit must be personally performed by the physicians, as we mentioned before. And OHIP cannot be billed by delegated procedures when performed by an NP who's employed by another organization. So if you have an NP within a family health team working together with you as a physician, you cannot bill for the services that they provide. They're getting paid through another manner. So that is why. Next slide. So let's look at the examples of the delegated procedure that are in the scheduled benefits. So the concept of being able to do a venipuncture, take blood, any injection or immunization, ultraviolet light therapy, oral polio vaccine, which is rarely done, simple office procedures. You look at your urine dips, your pregnancy testing, your rapid strep test, things like that are all would be included. Ear syringing, if it meets the criterion for billing OHIP, which is a whole other issue we can talk about if somebody wants to clarify that. Simple spirometry, so if you're doing spirometry in your office, and then casting, if you do any casting in your office. These are all ones that are considered not requiring the physician's presence that are designated in the OHIP schedule benefits. One thing I'll note there is, for example, liquid nitrogen cryotherapy, Z117, is not on this list. However, in my opinion, that meets that exception criterion. Nurse practitioners should be able to do that. That is easily trained if they've not already been trained through their training. And as a result, can be performed in your office and billed under your OHIP number. Because it's a procedure. They cannot bill at A001 or A007. Just again, making sure people clearly understand that. Next slide. So can an NP cover an after-hours clinic? So in an after-hours clinic in a FHO, the simple answer is yes. There's an application that needs to be made to the Ministry of Health, which we will be making available at a later date with our when we put this on the online platform, which needs to be filled out. It usually takes about 2 months or so to get the ministry to approve it. But it's pretty much a formality. So the idea is that a nurse practitioner is allowed to do 1 after-hour shifts per week for your FHO group. And the other thing that's really important is that with this registration process, nurse practitioner also has their own 6-digit OHIP number. So if they are performing things like prenatal care or physician's home visits or even some surgical procedures, if they bill your patient using their 6-digit OHIP number, it becomes a tracking code in the background that moves towards your prenatal care bonuses, your home visit bonuses, and your special office procedure premium bonuses. So they do not get paid for the specific prenatal service, but it relates to that bonus. I think you need 5 prenatal a year, 5 home visits a year, and I think $1,000 of office procedures to get those premiums. So important if they are performing them to ensure that billing is happening in the background. Next slide. Let's talk about the payment model or the business model for bringing a nurse practitioner to the practice. So I'm going to go through this slowly and carefully for those who may not fully understand. So when we talk about the full payment model, that is a capitation-based model of payment. But there's 4 different components to this payment that physicians will make. They have what they call their base payment, which is the essentially annual fee, one-time fee per year per patient that they get based on age and gender. There's something called a comprehensive care payment, which is related to the age and gender as well, but it's a smaller amount and it's providing your comprehensive care and being available for that comprehensive care and after hours. There's an access bonus payment. So what this is your after hours. It's a bonus that you get if your patient is seen by you and is not seen by another provider outside your FHO. So if another patient goes to a walk-in clinic or a focused practice physician who doesn't have focused practice designation and bills OHIP, you lose that billing number. So if they bill an A007, you use it. And that's what they call the access bonus payment. It's based on 18.59% of the base rate. And then the last thing is there's still a fee for service payment. For everything that we bill when we see a patient, we still bill our A001s or A007s or K005s, whatever it may be. We make 15% of that payment in fee for service. So that together encompasses our total amount that we would make on an annual basis per year as a family physician in a full model. So now when I look at this, we're going to go to the next slide, which shows you a breakdown of payments. It's the next slide after that. So we're going to make some assumptions here when we go into looking at the business model here. One is you have a well-balanced practice. You have a balance of age groups across your practice, and you're not dealing with everyone in your practice being over 65 or everyone in your practice being under 20. It's a well-balanced, comprehensive family practice. And we're also going to make the assumption that you're maximizing your access bonus. And we can talk about what happens if you're not maximizing the access bonus, how it could change your calculation for your rostering for patients to bring on a nurse practitioner. And we're going to exclude any fee-for-service payments here. So let's go to the next slide. So this is the full model, annual payments based on the gender being female patients in your practice. So we have the age of the patient, we have the base rate, adding the comprehensive care payment plus the access bonus. So what this does is we know from a 0 to 4-year-old patient, you on the average would earn $198 per year. A 50-year-old female, you would earn $291 a year. A 90-year-old female, you would earn $768 a year. But what we're going to look at here is on the average, it being $312 per year based across all the age and gender models. So that's the average income you would earn per patient per year that is rostered a female patient in your practice. When we go to the next slide, which shows males, you're going to see the value is less. And we know that for a 0 to 4-year-old male, the average would be 208, a 90-year-old male, 718, but the average is $262 per patient per year. So based on this, when we look at the access bonus, we see the access bonus represents just a little bit over 10% of the total amount that you make. This is again assuming that you're making 100% of the access bonus. So let's just throw out quickly a number for semantics. If you had only earned 70% of your access bonus on average, then you're looking at about $24 for the access bonus. I'm just quickly math in my head. And so that decreases maybe your total amount of $10 per patient per year. But it's important when we look at these numbers, when we go to the calculation of rostering patients by that allows you to pay for a nurse practitioner in your practice. So going to our next slide, we're going to combine male and females, and we get an average payment of $287 per patient. So this is looking at the base rate plus comprehensive care plus the access bonus being 100% without a fee-for-service component. So we're going to go to the table then next, which shows a little bit of a breakdown. So I'm going to explain this. What I've done here is I've assumed a nurse practitioner would be working on an average of a 37.5-hour work week. And then we played around with some examples of potentially hourly rates, anywhere from the $70 to $85 range. And as Nour said, this isn't to imply this is what the payment should be. I think payment needs to be based on the employee's experience, the volume of patients that they see in a capacity per day, and what the employee brings to the table, and that negotiated settlement between you as a family physician and the nurse practitioner, what you guys agree upon. But nonetheless, when we look at the various hourly rates, I gave you a weekly rate and an annual rate. But what I've done with it, based on the annual rate, let's say of $70 an hour, $136,500 per year, if you had brought on a nurse practitioner to work 5 days a week in your office, you theoretically need to roster another 475 patients. That's based on the $287.42 model. If we look at the salary rate of a nurse practitioner being at $85 an hour, or $165,750 per year, then we're looking at 577 patients for a full-time practice. I've changed it or put it into the column before that as how many patients you need to roster per day, because as you're going to hear from myself and our other individuals on our moderation panel, we do not have nurse practitioners in our practice working full-time. We have them working part-time. So this looks at how many you would need to roster per day based on if you have them 1 day in your office, 2 days in your office, 3 days, et cetera, but you can multiply that number. So it just gives you an idea of the number of patients to roster to kind of get a sort of revenue neutral approach. Just going to go to the next slide. So things to take into consideration though when you're looking at this business model. Do you have the physical space to accommodate a nurse practitioner in your office? And if you don't, do you need to increase your rental space? And what's the cost related to that? So this is something that you need to have an understanding of what your rent cost is per square foot per month, and look at that calculation and then play with that $287 value to calculate how many more patients you may need to roster. However, we do know that a lot of individual physicians who work in group-based practices, there's always somebody who's not working a half day here, a half day there. And we have vacant exam rooms. So I think this is something to remember to consider is how to use that physical space that's vacant, which essentially you're paying for to ensure that, that you're using your office space efficiently for the employees that you have. You also need to look at, do you need to increase your medical office assistant time to accommodate the nurse practitioners? And that may need to be done depending on the volume of patients they're seeing, whether you're working together with them in their office or whether they're working a day in your office when you are out doing something else. The cost of the supplies that may be related to the nurse practitioner activity. You need to think about what happens with the roster patients if your nurse practitioner resigns. How quickly are you going to be able to hire somebody new? And whether you're going to be able to accommodate seeing those patients, providing access to them in the interim while you're trying to hire on a new individual to work with yourself. And then looking at ways that we could share the NP amongst providers. So this is where, when I look at group-based practices and individuals, we're looking at increasing access, but also looking at individuals in practices who are looking at doing other things, whether they be focused practice work or other type of subspecialty work or other type of leadership work. So, for example, that's what we've done in our office. So the nurse practitioner is shared amongst 3 family physicians that I work with, and we have other nurse practitioners that are working for physicians in our group, in our practice, but our particular one, they're shared amongst 3 of us, so that each individual physician has them so many hours or so many days per week. So we'll go to the next slide. A nurse practitioner can also be used as a locum in your office, the same way another family physician could be working as a locum in your office. So it's important that you have a locum contract the same way you would for another physician. You need to establish what you feel the hourly rate would be, and that would be negotiated with your nurse practitioner locum. You need to understand that the delegated procedures, which ones they can bill under your number, and to ensure that if you want them to do that billing, that they're trained. If you have a medical office assistant that can do that billing, that they are trained, or whether you yourself as the physician are going to need to do that billing yourself. Other things that NP locums are doing are coverage for inbox management while on vacation. And one of the things we're going to talk about is how options for finding an NP locum in the future. So we're going to have Andrea talk a little bit about that when we introduce her again. So next slide. Oh, there we are, Andrea. I'll let you introduce yourself, talk a little bit more about your role.
Hi there. Yes, very soon you're going to receive an email through one of the channels that reaches family doctors in London and Middlesex with my contact information. And I'm going to be doing the recruitment, but also locum management. So you will reach out to me if you know that you're going to be moving or transitioning to practice in any way, or also if you need a locum. So please note my email address, and if you want to call me, you're welcome to. Please do let me know how I can help you match with a locum, because we often have international people coming to London to just try out if they want to be here, and they'll come for a set time. So like, for example, I have somebody coming from Saskatchewan for 2 weeks in March. And so I'd like to be able to communicate with the doctors in the area to say, hey, does anyone want to take 2 weeks off in March? So there is talk of a faster way for us to communicate than email, and I'll post that all through that email that you should receive shortly. Thank you.
Thanks, Andrea. I'm also going to mention that Andrea's focusing on Middlesex London area, and we know we have individuals joining us today that are outside the Middlesex London OHG geography. And some of those individuals also do have recruitment advisors or leads within their own geography. And that is something that Andrea will be meeting and has already met with a lot of them. So there'll be a lot of cross-pollination amongst themselves. So thanks. Where we are, next slide. Right, so we are at the panel. So maybe we'll take down the slides so we can kind of see everyone. And I think, Nour, you're going to do some moderation, I believe, on that, right?
Yeah, sure. So basically, we're just kind of going to keep this informal-ish. So, like, I mean, our main thing is to answer questions of people who are currently here that if you feel comfortable, you can unmute yourself, or I mean, if it gets messy, you could always just do the raise hand and we can call on people based on order. You can type your questions in the chat box and we can read them out and go over them with our panel members. And then we also have some questions jotted down from when you signed up and questions we've received in the past that we can also discuss as we wait for questions to generate. But I'll just take a second just to, I know that Tracey and Jerry have introduced themselves already, but they are here, and welcome. Thank you for taking the time to, and Gord as well. So they're the experts. I will be the one that's going to just try to coordinate and ask the questions, and they will have the great answers for us. So we can wait for some questions. I'll wait a second to see if anybody raises their hand, and if not, I'll just start with whatever questions I have jotted down here. Okay, we have Brianna.
Hey, good evening. Nice to meet you. I just was hoping that maybe you could provide some examples of how the nurse practitioners are working in conjunction with the physicians to kind of manage larger rosters. So, you know, in our family health team, quite large, we do have 5 nurse practitioners that are full-time, and they really function more completely as independent individuals. So they see our patients for us, follow up on blood work, but there's not really like a collaborative relationship in the sense that, you know, they're not reviewing our inbox, they're not helping us to kind of manage the practice. And, you know, with the thought of doing this kind of work and looking at that collaborative relationship, you know, in hospital setting, for example, an inpatient, there's a much, I think, closer collaborative relationship that occurs between an NP and a physician, right? That's seeing a patient in the hospital. You know, we work together, we see the patient together, we would go over the assessment and plan, and we kind of work together to kind of optimize skill sets to be able to see them, you know, the most patients possible and provide kind of the best care in hospital. I was just wondering from our panelists how they see that working in their day-to-day practices, and if they have suggestions or examples of ways that they work with nurse practitioners individually to help offload, especially the administrative burden, and maybe some other things outside of the box that we haven't really thought about in ways to be able to leverage our nurse practitioner colleagues and their skill sets to kind of help us be more effective, and not even just provide access, but just provide good care.
For sure. Thank you for that question. Yeah, I just want to clarify one.
Yeah, go ahead.
Go ahead. Okay.
No, I was going to say there's lots to unpack there, but if you want to clarify something, that's great. Go ahead.
Yeah, sorry, Brianna, I didn't catch where you work and how, at what capacity the NPs, like, is it, are they employed by the physicians as a fit model? I just missed that first part there.
Sorry, I didn't say. I'm in a family health team in a fit model. They are employed by the family health team. So there are a few exceptions, but most are employed by the family health team. So the physicians have their rosters and the nurse practitioners are available to help provide access and see our patients, but it's not a very close relationship where I would work with a particular nurse practitioner always, who would always see my patient, that we would have ongoing kind of dialogue and collaboration. And I think a lot of it is related to style of practice for a particular physician, right? The way that we like to manage our practice and handle our patients. And that really, I think, would lead to a better experience, you know, if you could develop that.
Of course. Okay. Thanks for that clarification. Gord, go ahead.
So I'm gonna definitely let Jerry and Tracey also make a comment. There's one thing that I really want to stress that's so different in the business model that we brought up. By having a nurse practitioner work more intimately. So for example, Jerry works with myself and Tracey and another physician in our group. And by seeing our patients regularly, there's an established relationship that develops with him or our nurse practitioner, as well as it develops with us as a family physician. So there's really an important element for us to learn to communicate with our nurse practitioner, especially in days that I'm not in the office, and how we communicate with patients to ensure that continuity happens in between the providers. Because we also know that we have certain types of patients could easily do like the old mother and father play each other against each other concept, and we don't want that to happen. But we also want to ensure that we are aware of things that are going on. So that's a real uniqueness into our practice. So a lot of this is really ensuring that we have a physical touch base multiple times in the week, but also we have the virtual touch base using the EMR about patients, forwarding messages about, say, hey, this was an abnormal result, wanted you to be aware of this, I'm following up on it, that type of thing, and vice versa. So I may see an abnormal result on an individual patient that my nurse practitioner that Jerry has ordered, and I will sort of say, I followed up on this, but just letting you know this is what's happened with this patient. So it does become collaborative and open communication really important. The other thing I was just going to stress is that we know that family health teams use their nurse practitioners in various different ways across the province. And so Some have their own roster, and some work to look at access, and some do specialty care. So that whole element of how the fit-based NP is working in your fit may be very different than the other fits, for example, where they may be more supportive of the family physicians providing care. It really just all depends on the particular fit. But definitely, I want to leave Jerry to make some comments about how he sees the role from the nurse practitioner point of view, because I also know that Jerry has come to us from other offices work before he came to us, so he had family physician experience, and so that was helpful for us when we were hiring him on.
I think from a practice perspective, there's a huge variety of where NPs are working. You have, these NPs that are in family health teams that are doing focused practice in, let's say, COPD, heart failure, that sort of thing. There's also NPs like myself doing sort of fully fledged, primary care provision. I think it's important to sort of have that discussion with the NP and figure out what their sort of plans are and what their skills are as well. The training can be a little bit varied as well. I think that's something to keep in mind too. I've had, luckily some very great physician and NP mentors, and that sort of got me to where I am now. And in terms of, patient volume and, inbox management, I'm pretty self-sufficient. And in my role here with covering for Dr. Ouellet, Dr. Schacter, is to pretty much try to offload as much as I can from their day. So I will take on all of their the medication renewals and a lot of the faxes that come in regarding patient tests or specialist notes the admin will send to me, and I'll process them, update their patient profiles, or if a patient needs a follow-up with me, we'll have them booked in, and really just try to make the team-based care as as efficient as possible. That's our goal, right? To make it so that the access to care is good, patients are getting high quality, effective care as well.
And I would just sort of add to that, your question's great, Brianna. And we also are in a fit model. And we're a small fit, so we actually only have one nurse practitioner working with like 16 physicians per the fit portion of it. And our nurse practitioner with the fit just basically provides a bit of additional access. So, you might have access to 1 or 2 appointments, every day or so if you need it at most. Whereas the big difference in working with Jerry is it's more like you're sharing your practice. So the other NP may see someone for me that I wasn't able to fit in that day, but with Jerry, to Gord's point, you get that continuity of care. The patients know Jerry. They're happy to see Jerry instead of me. It doesn't really matter. We've become quite interchangeable with each other. And if I'm not there or I'm away on vacation, I know that everyone is going to be happy to see Jerry, and I'm not getting any pushback in terms of, patients not wanting to be seen by someone other than myself. And then to Gord's point, the communication is key, and we help each other. Like Jerry has skills and does certain things in the practice that I no longer do or I don't do, and vice versa. So we sort of, divvy things up based on that as well, which is just better for the patients in general. So it's more the concept of sharing as opposed to him just sort of being someone on the fit who's kind of servicing the general population of the fit. It's more like the concept of sharing the management of my practice with another practitioner. That's how I see it.
I'm just going to also just explain briefly, like for me and as an individual, how this evolved into bringing on a nurse practitioner. So a lot of you are familiar with me, and I've been doing leadership roles for a number of years. And so as I took on more leadership roles, it was either I reduce my roster size in order to work 3 days a week, or I bring on somebody else. So I actually worked with a couple of family physicians over the years who worked a couple of days in my office, and we shared the practice. And it became a point that it was becoming harder to find a family physician to do that locum position. And that's where the opportunity for the nurse practitioner came up. And in essence, and I'm going to ask Tracey maybe a comment about changing, but Tracey has brought on nurse practitioner students for a long time. And that's allowed us to have a better understanding of what are the skill set, the role of a nurse practitioner, and how to work together with a nurse practitioner. So maybe Tracey, you can make some comments on that.
Sure. Thanks, Gord. Yes, I kind of stumbled into the role kind of by accident when one of our former FIT NPs had a student who wanted to spend some time with a family physician. And I was like, sure. So for several years now, I've been taking students from the nurse practitioner program at Western University, and I have them most of the year. So their clinical year, which is the second year of their program, their first year is a master's, and then they have their clinical year for their second year. There's 3 blocks of training that they do that are all clinical. So I have typically 2 to 3 NP students at any given time throughout the year. And it was a great experience for me to really educate myself about how an NP can complement my skills as a physician. And I'm old enough that I'm part of the same generation where it was like, oh my goodness, are the NPs going to take over our jobs, et cetera, which is quite funny to me now because honestly, I think it's the best thing that I've ever done. I thoroughly enjoy the teaching aspect. These people are highly motivated. They're quick learners. They're eager to expand their skill set and take on those responsibilities. And obviously, when you hire an NP, depending on kind of what you're wanting from them, you're obviously going to take that into account in terms of their level of experience, because a new nurse practitioner obviously is going to require more support initially in terms of, that learning curve, as we all did when we were new young physicians at one point. And then the experienced NPs, they basically operate very similar to ourselves. But the one thing I would say is that they are nurses. And so they do have a background of training that is extremely different than ours, I would suggest. And they bring a certain skill set to that patient encounter and a certain, demeanor that is a little bit different than ours. And I feel that it's very complementary to the way we deliver care. And you'll certainly find that there's certain patients that would actually benefit greatly from that perspective that the nurse practitioner brings to that patient encounter. And like I say, I feel like it's based on that nursing training and those nursing years experience, like Nour alluded to. They just bring a different package to that primary care environment. And I find that it's very beneficial and very helpful.
Thank you, everybody. That was phenomenal what you just said. Thank you. Wow, that was great. Thank you. So I'm just going to work my way up in the chat here. Now, there's one question that kind of veers away from what we're discussing, but I'm just going to say it quickly and then go to the next question, because I think it kind of relates to what you were saying, Tracey, just about students and meeting NPs and trying to incorporate them into your practice. But Jessica's asking, in all of your discussions with governing bodies, have you heard any discussions about NPs working in pediatric primary care offices?
I'm happy to take that, Nour. So the challenge in pediatrics is your payment models are fee for service unless you're on some type of alternate payment plan. And the challenge in a family physicians who aren't in a capitated model, so in fee for service model, is that because you cannot bill for the assessments, then there's really you can't make a business model for bringing on a nurse practitioner. And it's quite unfortunate. It's just the way the current state is. As Nour said at the beginning, we do not have a perfect system, but it is the way it is. So the bringing on the nurse practitioner and the capitated model of payment, a full model of payment, is basically a nuance that a number of physicians have recognized over the years as a way to increase access within their practice. So it has been used especially in some rural communities. I know of a few rural communities where there's only 2 or 3 family physicians, but a large volume of unattached. And those family physicians brought on nurse practitioners and rostered more patients just for this aspect of just ensuring that that geography has access. And so it's, part of it is, as I mentioned before, it's that business case you need to look at. Do I have the physical space? What is my rent cost? What will my MOA requirements be to bring on somebody new? But it's working out the numbers. So I try to give some background on the capitation volume that you need to do. But unfortunately, I wish there was a way the nurse practitioner could work in the pediatric practice. The only other thing I would mention is the concept of trying to explore physician's assistants out there. And that isn't something we've explored too much in detail at the OHT yet. But the physician assistant has an element of some things they can do autonomous, but because they cannot prescribe, there's still an element that as a physician, you need to still see the patient. And if you're still seeing the patient, then there's probably a way that you can bill for that service that you're doing in some manner. And so it's just a matter of really understanding it. Back in September, there was an opportunity to get some funding for physician assistants, and maybe that'll happen again next fall. It was 1 year's worth of seed money, I believe, for a minimum of 2 years afterwards of commitment for bringing on a physician assistant. So the idea is you can't just keep getting seed money. You have to make a business model to continue having them employed and continue working. But I think it's something to look at as a way of bringing in other integrated health professionals to work together to increase access to a primary care provider.
Thanks, Gord. I'll move on to the next question. It's just switching gears back to what we were kind of discussing before. This question is from Kelly. So as a new nurse practitioner living in Middlesex County, I found it difficult to find non-contract employment or employment for new NPs with less than 1 year experience. What support is there for NPs to become connected to primary care employment? We hear a lot about lack of primary care providers. However, it's often difficult for us new NPs to help figure out where we can fill that gap on our own. Is there active recruitment and retention efforts for NPs in Middlesex, London? Thank you for answering my question. I'm just going to quickly chime in to say that what we hope today, just from this experience, is that we can get a sense of interest and we can maybe help, whether it's through Andrea or through the LMPCA, just to help connect people who are interested, NPs and MDs alike, to bring that connection together. I saw a similar question just about, getting NP students and then moving, if things work well, to turn that into an employment opportunity for the NP. This is kind of similar. I'm just wondering, if there is somebody here who has interest in hiring an NP who wants to work with an NP, that we can make that connection. But I'm going to open the floor just to our panel members and Gord as well to see what their thoughts are.
I think you're right, Nour. One of the reasons we're doing this information session, this town hall today, is just for that case, to make sure that more family doctors are aware of this potential business model and the benefits it would bring. And so that's part of it. The more we can get the word out of this as a potential business model, then we have that idea of increasing access to for patients who don't have primary care providers. But the challenge is it is an independent business model, the way family physicians work, and so sometimes it's herding cats. It's getting people to move beyond that level of uncomfort to try something unique and different, and so. We're going to try to ensure that people are aware of this session being recorded, that my email is accessible at all points. I'm happy to help people out and connect them with individuals who can give them advice in vendors' manners. And I'm sure Tracey and Jerry would as well be happy to talk with people. But it is an ongoing challenge. There's no doubt the way the system is. And, having the Andrea Lowen now, having her in her role as a primary care recruiter, it's going to allow us to also potentially create those, lack of better term, marriages for individuals like yourself who are looking for work, but also for physicians who maybe started to think about this concept. And as Andrea goes around and starts talking to physicians, this will be something that'll be in her bag of tricks to say, have you ever thought about bringing a nurse practitioner into your practice a day a week, since you want to do something else a day a week, for example? Let me see if I can help you find that and find those individuals, because it may be 5 different physicians in 5 different practices that all want somebody 1 day a week, but then we have full-time job for 1 nurse practitioner. They're working for 5 different people, but that's one way of, we're looking at how this could be done.
Yes, just to comment more on that, Gord, I was in Dorchester today. So there is a family doctor who's going to be retiring in a few years, and he has a huge practice. So I know that whoever's going to take over that practice probably, will need some assistance. So I will likely be keeping track of nurse practitioners who would like to join. So you're welcome to email me, and I will keep a list of everybody and try and make the match, as Gord said.
That's great. One coordinated effort kind of allows for this type of magic to happen, which is really nice. There's one question here from Nisha. How do family physicians have to budget to be able to employ an NP? What difference in roster size does having an NP make for you, i.e. 200, 500 patients or more?
Who would you like to deal with that, me or Tracey?
I can do eeny, meeny, miny, mo.
You had a bit of a slide up, I think, Gord, right? With the dollars part of it at the beginning.
Yeah.
I don't know.
So I'm not sure if you missed that, Nisha, but definitely the idea is that you're going to need to, if you're going to bring on a nurse practitioner in your practice, to increase access within your practice, and there will be a need to ensure that you have a revenue neutral approach. You don't want it to be costing you, and hopefully there's a way you can look at it actually benefiting you from the point of view of the administrative load on you. So looking back at that slide, the numbers on to the right in the red would be if you had a nurse practitioner working full-time 5 days a week at 37.5 hours a week in your practice, how many patients you would need to roster on average. And again, this is assumptions that you're making 100% of your access bonus. So, but it also is not including your fee for service. So yes, you could say, well, if I have less than 100% of access bonus, I may need to roster more, but you've got to remember that you're also earning some fee for service income. So that probably kind of balances out to make sure that these numbers are fairly realistic in your numbers. And then, when we look at, there's a lot of talk, if a discussion regarding nurse practitioners taking on their own roster out there in the community, and what would be the average. And I think most nurse practitioners probably, I'm going to, Nour, you can correct me if we're wrong, who are looking at rostering, whether it be a nurse practitioner like clinic or FITs that are bringing rostering, are looking around a 600 patient roster for a full-time position. That's the number I'm hearing. I'm just wondering if you've heard the same.
I feel like I was hearing 800.
Okay.
But
yeah, which is even
Gary's
more than
nodding, so maybe, yeah.
Yeah. So it's interesting, right? So the idea of an 800 for a full-time practice. So this just shows you that if you were to bring on a nurse practitioner who can function at a high level, you actually may be able to roster, let's say if you're paying them $80 an hour, and to throw out a number, you may be able to roster more than 543 patients to make it more than revenue neutral for you, to allow you to ensure that overhead cost, if you need to increase a medical office assistant or increase lease space, would be worked into that equation. There still may even be a small element of some profit, depending on how you run your practice, right? Not to say that this would be the reason for you to consider doing it. I think the big reason for considering this is physicians who are looking at stepping away a little bit from their practice or finding the administrative burden so difficult that they're finding themselves burnt out. This is a way of bringing somebody in who can help with that. So another reason to not consider rostering the larger volume, to keeping that volume down to make it revenue neutral, so that nurse practitioner does have the time to potentially do some of your inbox management, for example. So I hope that helps, Nisha.
I think it's also just important to note that a lot of our capacity as NPs when we work in NPLCs or FITs is a lot of the times we don't have the amount of admin support that would require us to see patients quicker. So I know that working in, and I mean, Jerry could speak to this more, but I think if there's more support that way, that there is more productivity with the amount of patients seen and that type of thing. So theoretically, I would think nurse practitioners could work at a faster rate than what that 800 patient roster would be. So question from Shamina here. The first part I'll just answer quickly. It's, can you please briefly explain the RNEC and NP training pathway? So RNEC and NP are the same thing. So registered nurse in the extended class is what a nurse practitioner is. In terms of the training pathway, you do have to obtain your bachelor's as a nurse, so a Bachelor of Science in Nursing. You need 2 years of full-time experience as a registered nurse at minimum. And then you enter you get a Master's of Nursing. So there is a collaborative program that marries the MN and NP program together. So the Masters of Nursing and NP training together, which is 2 years. Or if you want to do your master's separately and the NP training separately, you could do that as well. So that's basically the training that comes behind it. For number 2, the newly rostered patients, how much time would you allow for NP to see these additional patients and get them on their way before starting to make an impact on doctor's original roster? So I wonder if Tracey or Jerry, I don't know if you guys want to tackle that part of the question there.
So is it, if it was at like a new green NP kind of thing, am I interpreting that question correctly in terms of how much time allotted per visit? I mean, I think.
Sorry, I'll just clarify. Can you hear me clearly? Sorry.
Yes.
Yeah.
Okay, very good. It's more along the ways of, or along the lines of, okay, so that those additional patients have been rostered. The assumption is that those patients have been unattached and need to have their health issues collated. I need to have them addressed, kind of quote unquote, on their way in terms of investigating, managing issues, and that always takes a period of time, right, to kind of meet them and, like I said, quote unquote, get them on their way and get them sort of stabilized. And my experience was, when I was taking on new patients as a newly qualified family doctor, it did take me a period of time to meet those individuals, to sort of unravel what was going on in terms of their health needs, get some investigations underway, referrals underway, and then maybe after a period of time, I didn't need to see them as frequently, right? So I can appreciate that when these patients are rostered, it will take the nurse practitioner a period of time to kind of do all of that before they can then perhaps, not that they wouldn't be seeing those originally rostered patients of that physician, but I mean, what would you, maybe this question is ridiculous. It's like asking how long is a piece of string, but I mean, what would you feel comfortable with from the NP perspective? How much time would you say, okay, I've got these 95 patients or 100 patients, and it might take me 6 months. It might take me, 9 months to kind of meet everybody and get them on their way.
Yeah, that's a great question. It's hard for me personally to answer that, Shamina, only because in my personal situation with Jerry and the NPs that we've hired in the past within this particular model that we're discussing, I actually didn't intentionally or consciously roster extra patients for the model that Gord has proposed, because we share the NP role, like from a financial perspective. The financial hit to me was in my world not overly significant, and the purpose of me having an NP is more to do with work-life balance, mental sanity, avoiding the infamous burnout that's a very trendy word in primary care right now. Having reassurance that if I want to take a vacation, that I have someone that can just jump right in. And fortunately, I work with colleagues, Gord and Rashmi Bala, who are incredibly supportive. And so when I go on vacation or when they go on vacation, it's all good. We're like, yeah, let's split our days with Jerry, and I know it's covered, and I'm not stressing about finding a locum. If I have to go and attend something for one of my kids and take a day off, and even if it's last minute, there's always that buffer there. And to me, like, you can't put a price tag on that. It's more than worth it for me. I think obviously if you were intending to employ the NP for like a bigger chunk of the week, then obviously, of course, you would have to adjust your roster to accommodate that, because obviously we're all, struggling in that regard in primary care. On the financial side, our expenses are obviously only increasing. So I'm not trying to ignore the significance of that factor. But I would suggest that you could, the NP, at least the NPs I've worked with, they're very comparable. So I feel like whatever period of time it took you to bring on your new patients when you were just starting out, I would suggest, particularly if you got an NP that has some experience under their belt, that it would be not dissimilar or not overly dissimilar to the period of time it took you to take on those patients. I think that that's a fair assessment.
I would also just comment on that is that, part of this is going to be your confidence in the experience that the NP has that you hire, on the volume that they feel that they can see. And that is something I know there's some questions which we'll try and get that answered shortly. So that there may need to be for you to balance you seeing some of those new patients and the NP seeing those new patients. If you have the NP seeing all the new patients, knowing that those new patients have complexity that they're coming with, that the NP may not be able to see the volume that you need to make your business model. So you need to find the quick upper respiratory tract infections, the UTIs that also the nurse practitioner can see in the day, that's going to allow you to see the complex patient. So how you find the balance between the workload and how your medical office assistant staff can arrange that balance in the workload.
Sure, and that makes sense, and I can appreciate that. Yeah. And then I've got a couple more questions here, if that's okay.
Yeah, go right ahead.
The next question is regarding where could I find the pay scale, or an example of a pay scale for NPs, and years of based on NP salary based on years of experience. I don't know if I can find it easily online, or if somebody could kindly consider emailing that out. That would be really helpful.
I'd say that's a super tricky question to ask. I think Jerry, like, I don't know if you feel comfortable, just, you don't have to say numbers or specifics, but is there anything you'd want to add in terms of comments? It's just hard because this is a model that doesn't really actually exist. We're kind of working within the constraints, and then you have NPs that are hired that are government funded, where there is benefits and leaves and all that. So then we can't really compare that with this. So it's kind of hard, but I don't know, Jerry, if you wanted to tackle it, if you had any insight, it would be more than what I would know. So
yeah, of course. I'm more than happy to answer this. And I think this will tie into the questions that Sarah and Brianna had as well. Really, it sort of depends on the skills and abilities that the NP brings. I came from a place where there is a family physician that had a 5,000 patient roster, right? And we actually had 3 NPs. We had a team of 6 RPNs, and I was seeing 30, 40 patients a day with all the admin support, and that was a big factor into the sort of pay scale as to what I am currently getting from the physicians here. Looking at the slide that we had on PowerPoint, I think that is a good starting point. You can also see the publicly available information for NPs getting hired at LHSC in terms of their remuneration. The only thing to keep in mind is that there is a benefit package and pension package that the NPs do get at the hospital. And that's, I think, a part of the reason why the hourly and yearly salary is a bit higher there. And I think that comes into part of retention as well, because, ideally, if you're hiring an NP into your practice, you do want to be able to have someone that's going to stay long term and, have someone that your patients are familiar with. And, you want to have someone that's reliable and that's going to be there for your patients, because ultimately it's your business, right? And, it's your baby, right? I think that's sort of the term that Tracey had said to me before as well. So I think it is worth it a little bit to sort of, see the NP and then their value and maybe paying them a little bit on the higher end of scale for them to stay there and continue to work hard and provide value for your practice.
And I think you raised some really important points, and that leads to my fourth question about benefits package for an NP working in like a FHO doctor's or a private doctor's practice. I'm just wondering if the docs can comment on this, because I mean, retention is key here. If I hire somebody, first of all, how am I going to entice somebody to come over? What can I offer? And I appreciate what Jerry has said in terms of, a competitive salary. And then what about benefits? Is it expected that those are, that's part and parcel of the deal? Because as far as I know, I can't take out a group benefits package for my staff, right? So just some suggestions there, if anybody has any.
I might be able to answer that.
Wonderful, thank you.
Okay, so my other hat is that I'm a co-owner of a clinic with 6 doctors in FHO, and we have a benefits plan through a third party. So it just depends on how many employees you have, and you can find benefit packages through third parties, and I can provide some companies who do that, and then it's up to them if they'll just tell you how much it costs and for how many people. So we have a healthcare spending account, right? So it's just a lump sum amount, and then it's not specific benefits like for glasses or whatever. It's just a total amount. So it depends on how many employees you have, though. So if you have a smaller practice and it's just yourself, then I don't think you would be eligible for benefits from what I've read.
Yeah, and that's where I'm coming from. It's, I've only just got an MOA, and then if I brought, an NP, and I still wouldn't qualify. But the what you said at the latter bit of your explanation, the health spending budget, maybe I need to look into that.
Shamina, we don't offer benefits. So, and Gord and I have hired, like, over the years, we've had a few different NPs, which you could argue maybe there is a retention issue. But, we're actually part of a FIT that doesn't actually really, I think they do like some kind of in lieu thing with the FIT. On our particular team, we don't have the hoop benefits that the Thames Valley team has. But I do not offer benefits to my employees, including Jerry. I think I wish I could. It's just not feasible for me for the same reasons as it's not feasible for yourself. Just working with the NP students over the years, I think a lot of them just genuinely have a desire to be in primary care. They don't all want to be at the hospital, as enticing as the situation at the hospital is. In fact, our family health team employee, NP, left the FIT, went to work at LHSC, only to come back to the FIT. Because it was just a job that he didn't particularly enjoy, to be honest. So I think part of it is just the NP's desire to work in the primary care environment, and a willingness in some cases, to sort of negotiate a scenario that is affordable and feasible for you, the physician, which still offers them this opportunity and experience that they may desire. I don't know if Jerry can speak to that, because obviously he is the NP living that experience. So
Yeah, I mean, with our training, the emphasis really is on providing high quality primary care, and we get all this training with primary care, and really the lack of jobs is it's difficult for us, right? And that's why we find ourselves going to the hospital and working these sort of very niche surgical or medical type programs. Speaking back on Kelly's point there, it is very hard to find a program right now for NPs to work in primary care, despite that huge number of unattached patients. So I'm hoping a program like this really will, maybe assist some of you physicians in adding on an NP to your team, because we really do want to be there to help your patients and provide high quality patient care.
That's wonderful. Thanks so much. And thank you for answering all my questions.
Great, thank you. The next question, I think, Jerry, you might be the best person to answer this. This question is from Sarah, and it's just about locums and longer term coverage for locums. Is that an appropriate thing for an NP to do? And within a busy practice, the idea or the thought is NPs are typically seeing less patients per day compared to a family physician. So do you think it would be appropriate for an NP to cover a mat leave for, say, 6 to 9 months? And how does that look in terms of access and maybe seeing less patients if that's the case?
Yeah, this ties into Brianna's question down there, which I try to answer as well. It really depends on the NP's skills and abilities. Like for myself on Fridays, which are my busiest days, I'm able to see 20, 25 patients and go through a lot of script renewals and all that stuff as well. And I think with that sort of volume, for the most part, you'd be able to take on a practice for the 6 to 9 month period. I know Gord, he's had a couple of vacations which have stretched a little longer, a couple of weeks, and it's just been me in the office trying to and covering his office, and that's been fine, and not many sort of really big issues. But it really is individualized to the NP that you hire.
Thanks, Jerry. This next question is from Misha, and this is a good topic to discuss, is how do you get access to NP students? So presumably you could potentially offer one a job if after you feel that they're a good fit. Jerry, do you want to take that question on? I know we talked about it during this process, so.
Yeah, so Erin Kennedy is the clinical lead for the Western Primary Healthcare Nurse Practitioner Program. I think looking at sending her an email just to know that, hey, I'm a family physician here in Middlesex, London. I'm very interested in taking on NP students. That'd be a great start. I know for a fact that they are actively looking for primary care placements for these students, because that's really ultimately where they want to practice, right? And I personally think it's a big disservice to these students when in their placements they're being sent on these sort of very niche specialties, like long-term care, for example, or if let's say, for example, a sports medicine clinic. With our program, we don't have a lot of placements. I believe it's only 4. It's not akin to, for example, my partner's internal medicine residency, where she's, on a different block every month. It's very different. So I think reaching out and being able to say that, hey, I'm here, I'm more than willing to take these students on, I think is a great start.
Thanks, Jerry. And I think what we'll do also is try to facilitate that too. Maybe just see if anybody's interested in NP students. We'll also reach out to Erin and try to make it more of a known thing. Maybe if you share your emails with us, we can make sure that the NP program contacts you as well as MDs who want to take on a student, because that's a great avenue.
And Nour, I'm just going to make a comment on that. And in my experience, I've done a little bit of coverage for Tracey with the students. If anybody has ever had medical students versus residents in their practice, to me, the NP students have a higher capacity than the 3rd year, 4th year medical student, but maybe don't have the full capacity of a 2nd year resident. So I've had some 2nd year residents in the last year. So there's sort of a balance when you look at how much autonomy they be able to do on their own versus how much coverage and work it is doing that teaching. And Tracey, you're probably the better one to do that, to make that comment. But I think that's important for people to understand is there has to be a time commitment. You have to be willing to teach, but actually it may allow you to have improve your access in your practice potentially.
Yeah, that's very, very correct, Gord. And I think when I first started taking on students, the NP program lead at the time, who I think was Wendy McCready, she was like, "Oh, I hear you have this big, busy practice, et cetera, et cetera. You might just want to take the NP students at the end of their year." So they basically start in September for their first block. It's like September till the end of November, beginning of December. And then they start another block in January till kind of end of March, early April. And then there's sort of like 2 6-week blocks at the end that take you into the end of July. And those, obviously, as they go through their year, they're gaining experience, as anyone would. And the final 2 6-week blocks that they call their IP, they're actually in your clinic full time, essentially. So they're basically there for the full week. And by then, they're basically almost about to graduate. So in those final 2 blocks in the spring and the summer, those NP students are extremely independent. You're obviously still there as a supervisor and a teacher, but they're basically operating quite independently. They're able to do a full assessment, physical exam, differential diagnosis, come up with the tests, come up with the prescriptions, that type of thing. So depending on your particular practice, your desire to teach, if you do connect with Western, you can specify when you would want those students. So you may or may not want them earlier on. I take them all year because I love it. And I think they're amazing. But definitely at the beginning of the year, September, you're going to have to spend more time and they're going to require more support, which is completely understandable because they're brand new. And depending on what nursing background they're coming from, they may be pediatric nurses. And so they've never seen a chronic disease patient who's, got all these multiple complex conditions, or vice versa. They may come from like something like mental health. And so their experience is very geared towards that. But there's lots of opportunities with Western to take on the students. And I definitely encourage you to do so. We have hired NPs, to that question, right out of that IP. So Gord and I and Rashmi have hired, my student in the past, just because we worked with her. She was amazing. She wanted to stay in primary care. It worked out quite nicely for us. So that is a great way to kind of have that experience.
That. Sorry, my internet's a bit unstable, so I think I was
Yeah, I think Nour, you're going to try again. You've had some internet instability. Not sure if you're back with us.
okay. Can you guys hear me now? Or okay, awesome.
Yeah.
So I'm just kind of going through the questions here. It seems a lot of them were already kind of answered in the chat. One that I was curious about, does this work in any way with long-term care? I don't know, Gord, you probably know the answer right off the bat.
Yeah, it is an interesting model. I think Dr. McNair, Sue, you mentioned that, and honestly, I've not done long-term care for a long time, so it would really need to understand the billing models for it. And I believe there's a monthly billing fee. There's some rostering that goes on with some long-term care. So I think you would have to look at the numbers and look at how much you get paid per patient and play with that number based on the 80 or $75 an hour, whatever it may be. But in turn, I think it also means you need to ensure that your nurse practitioner also is well experienced with disease of the elderly and the chronic disease management, to ensure that they have the skill set to do that work. So I think it's a potential there versus if you're on an alternate payment plan, there's something different, right? We saw, I think someone said here that Parkwood the veterans is higher than, and I think that's been through hospital-based hiring. And sometimes the hospitals will get into bringing an NP into this mix because they've had a hard time finding family physicians to do the work, or family physicians to be able to provide the after-hours call that's sometimes required for those long-term care institutions. So,
thanks very much.
Great. I think we're kind of nearing the end here. There's just one. I was just going through the questions that were shared prior with registration, and this question might be best for Jerry as well. Can an NP charge fees or collect payments from third parties for providing services such as completing forms like WSIB or dietary allowance forms or lawyer letters and that type of thing?
Yeah, that's actually a great question. In terms of the compensation for third-party forms, as a part of my agreement for my hourly salary, I don't collect payment for those. In terms of the ones that I do collect, the only thing would be WSIB.
But we do still bill the patient. So the patient is still paying. So the physician is collecting those fees. But that would obviously be another point of negotiation with your NP.
yeah, it's the idea if they're our employee and they're doing a form under our hourly time, then we're billing for the fee. So the WSIB, the NP is supposed to be billing under their own number. That's the legality element of it. And ultimately, it's because they're responsible, right? So there's that medical legal element of it.
Great. So now we just have a few minutes left. So maybe this is a good time to say, if you have any questions that pop up after this and you want to shoot it our way, feel free to do that. We're here to support you. The takeaways that I have here is we're going to try to connect with everybody through Andrea and through the LMPCA of interested parties, whether NP or ND or other, and try to be that common area where we can make those connections. I honestly it feels really great and positive to see both professions working together and collaboratively. And one of the biggest things that I thought was awesome that I didn't actually fully internalize is how it's when we increase access and work together, there's a lot of also decrease of burnout and more job satisfaction as well, which Tracey said really, really well. And I really, that was something that was great for me when we're looking at our healthcare system and the way it is now. So I'll just pop it to Gord here and see if he has any last minute things to say as well.
No, thanks, Nour. I appreciate that. And again, this is basically trying to give an idea of how to adapt and respond to the imperfect healthcare system that we have out there, as Nour said. A way of looking at increasing access for the unattached. So sometimes we have to look at our big system hats and decide, as we think of ourselves as taxpayers and some of the problems. And this is just one way, as a family physician working together with a nurse practitioner, we could make this revenue neutral and help decrease the needs of our population, decrease the emergency room visits for those non-emergent problems, et cetera. So trying to look at the bigger picture of how this could benefit. So just something to think about as well. Thanks.
Great. So I guess if there's no other questions, we can end today. The recording will be posted on the LMPCA website. It's just in the chat there. Andrea's posted her email in the chat as well, just in case you didn't catch it on the slides. If you have any burning questions, let us know. We're here to support you. Thank you for coming out today. This was great. And we hope for many more town halls to come. If you have any ideas that pop in your mind that you'd want to learn about or talk about, let us know, and we definitely want to consider those as well. All right, everybody, have a great night, and I'm sure we'll see you at some point. Take care.